to the American Journal of Transplantation Journal Club. And this is part of the AJT mini-series. And the theme here has been T-cell mediated rejection in transplantation. And then taken into prominent or exciting journal articles from the AJT to be discussed here in this conference. My co-moderators are Karan Kush from Stanford University, Sharon Chi from the University of Ottawa in Canada, and our panelists, our esteemed panelists, Luciano Portena from the University of Bologna in Italy, Sean Aguarino from the National Institute of Health, and Howie Eisen from Penn State University. And so the idea here is to talk about the two papers that were actually there before. Let me move on. Here we go. These are the two papers, and I'll have Karan and Sharon talk about these papers, just an update. And these were actually in a previous webinar, and I put the video linked down below if you're interested in perusing these two papers afterwards. We had the two corresponding authors, Greg Milligan and Priscilla Bilia, discuss their respective papers. Again, if you would like to get more in terms of what those papers were all about, please take a look at that video link that I put on the screen. All right, so with that in mind, let's get started. We'll have, again, Karan and Sharon talk briefly about these papers to give some background into them. Please, Karan.
Thank you so much, John. So I'll be introducing the first paper, which is Evolving the Surveillance and Workup of Heart Transplant Rejection, a real-world analysis of the molecular microscope diagnostic system. And this was submitted by Dr. Gregory Milligan and his colleagues at Baylor. As many of you know, the strategies for acute rejection surveillance after heart transplantation have been evolving, and we're now using a non-invasive molecular diagnostic approaches, as well as enhanced means for endomyocardial biopsy interpretation, including the molecular microscope. For practicing clinicians, when we're using these molecular techniques, we've often seen cases where the results are either concordant or discordant, and this can lead to diagnostic dilemmas and leaves us wondering, what do we do next? How do we interpret the results of these tests altogether? So this was precisely the question asked by this group. They performed a retrospective cohort study in which they collected test results from 135 heart transplant recipients who had donor-derived cell-free DNA testing, endomyocardial biopsies, and the molecular microscope performed. And what they found was that the molecular microscope and biopsy had 84% diagnostic concordance. 32 out of 37 discordant cases were classified as rejection by the molecular microscope, but not by biopsy. When they compared the molecular microscope to donor-derived cell-free DNA, they found 72% diagnostic concordance. And the majority of discordant cases were classified as rejection by donor-derived cell-free DNA, which is a very sensitive marker of graft injury, but not by the molecular microscope. And so I think this paper really kind of helps us frame where we are in terms of combining the results of these different molecular assays, and opens up a lot of questions, which we'll be asking our panel about what to do in cases where the test results are discordant. And with that, I'd like to pass it on to Sharon Chi, who will be introducing our second.
Thanks very much, Kieran. So the second paper you see up there on your screen that we will also be discussing was presented on the webinar by Dr. Phyllis Bellier on behalf of her research team at the University of Toronto. And it was titled Clonal Hematopoiesis Confers an Increased Mortality Risk in Orthotopic Heart Transplant Recipients. Their paper complements very nicely Kieran's paper that she just summarized, as they reported on clonal hematopoiesis as a potential new prognostic biomarker in heart transplant patients. So clonal hematopoiesis refers to specific gene mutations in hematopoietic stem cells that lead to clonal expansion and abnormal cellular function. And it has been linked to enhanced inflammation and adverse cardiovascular outcomes, including atherosclerosis. And based on inflammation being common to graft dysfunction, rejection, cardiac allograft vasculopathy, malignancy, opportunistic infection, and that these impact post-transplant outcomes and survival, the investigators hypothesized that clonal hematopoiesis may be an important prognostic marker in transplant patients. So they undertook a retrospective study of a cohort of 127 heart transplant patients who had had blood specimens collected at a median time of 6 months within transplant. So some before and some after transplant, but within 6 months. And they found a high 20% prevalence of clonal hematopoiesis, which is high compared to 5% in the general age match population. And in these patients, there was a significantly higher prevalence of moderate to severe cardiac allograft vasculopathy and higher mortality rates, with a threefold increase in mortality after adjustment of confounding factors that included age and chronic kidney disease and heart transplant indication. So these findings suggest clonal hematopoiesis may be a novel risk biomarker with important clinical utility for informing post heart transplant clinical trajectory.
Great, thank you for that, both of you, for this nice overview for these two papers. And again, the video link is on the screen, so if you are interested in getting into the hearing from the authors themselves, they have given a very nice detailed description of their paper. All right, so now we're going to get into this discussion, and I'd like to invite the audience to please chime in with questions. You can either get onto the Q&A field or to even that chat line. Either one will be reviewing them to make sure that we can answer your questions and put it on the panelists as well. And the whole idea here too is that, you know, we're really talking about biomarkers here. So, you know, whether it's the molecular microscope, cell-free DNA, whether it's clonal hematopoiesis, and what we call a CHIP in short, and we'll get into that. There's a theme that's here in terms of what's new and what will be new and what will be important as we treat our patients in the future. And there may be combinations of all these biomarkers that we actually use to predict who will do what and how we might be able to treat these patients to prevent rejection or even chronic rejection as in the future. All right, so let's get right into it. Well, I've asked Dr. Kush here to lead this discussion. We've got 6 questions. But Karan, let's just
Sure.
do.
I'm going to direct the first question to Dr. Luciano Putena, and this has to do with the molecular microscope. And so it seems like the field of molecular diagnostics is moving away from performance of invasive procedures in favor of more kind of blood-based, non-invasive monitoring techniques, such as gene expression profiling and donor-derived cell-free DNA. And so my question is, do you think the data provided by the molecular microscope justifies the performance of endomyocardial biopsies? And if so, in which cases is the molecular microscope particularly useful? Would you use it for routine surveillance, in cases where there's a discrepancy between the clinical presentation and the biopsy results, or to confirm and refine the biopsy-based diagnosis of acute rejection? Luciano.
Thank you, Kieran. Thank you very much. And I mean, you are raising very challenging question in which we don't have much evidence to debate about. So what I think is that when we put together all the diagnostic items that we now have available, we are looking at different things. So when we talk about non-invasive monitoring techniques with the biomarkers for rejection, is like when we make the diagnosis of myocardial infarction with troponin. And as a cardiologist, we know that troponin is not enough to say that is a myocardial infarction due to coronary thrombosis, okay? So that is the most likely cause. So I think that as well, for cell-free DNA and for the biomarkers that we have now close to the clinic, in particular cell-free DNA, rejection is the most likely cause, but it's not the only cause. So the point here is that we are looking at a complex scenario in which we may have an injury marker that may be caused by rejection, but may be caused by also something else, may be caused by coronary disease, perhaps. We have conflicting data about this. But anyway, it's something for which the current evidence is more clear when we have a negative cell-free DNA rather than when we have a positive. So when we have a negative cell-free DNA, we are confident that the patient has no rejection, has no causes of injury in the heart. So it's quiescent. And also from this paper, the largest concordance is for the negative. So it's very, it's easier to have a positive biopsy with a negative cell-free DNA rather than the other way around, okay? Then a negative, yeah, so I mean, you got what I mean, sorry. So the point here, looking at your questions, so do you think that data provided by the molecular microscope justify the performance of biopsy? I think that in general, to refine the diagnosis, we need the biopsy when we suspect a rejection. So if we are using a non-invasive marker to guide our suspicion for a rejection, I think that when we have this suspicion, we need the biopsy to get a proof that is a rejection, and also to understand what kind of rejection and which extent of rejection it is. So if we want to talk about what is the value, the added value of MMDX as opposed to histology red biopsy, this is again another issue, because it's interesting looking at the paper that we are discussing, because in our experience, in the experience of my center, we saw more often positive biopsies by histology that are read negative by MMDX, while in this paper is the other way around. So it looks like the crucial thing is, what are we comparing the MMDX to? So what is the gold standard and what is the truth? The general experience is that pathology reading is highly variable depending on the experience of the pathologist, depending on the centers, and the added value of the first added value of MMDX is that it's a standardized protocol. So it's a centralized lab reading, and we also know that if we have a centralized pathology reading, we have improved results. What we are currently missing is a prognostic indicator. So what is the most relevant prognostic indicator among all these biomarkers? We have some data, initial few data regarding MMDX and graft function related to injury. But I think that the problem here is complex and multifactorial. So at the end of the day, in clinical practice, I think that now it is relevant and would be advisable, when possible, to use a biomarker to rule out the rejection, and then to use a biopsy to confirm the rejection. MMDX appears to be more precise and standardized than pathology reading biopsy, but it's also more costly. So, and we still, in heart, we still don't have a clear evidence that gives a clinical advantage.
Thank you very much, Luciano. I think you brought up the really important point that although these non-invasive diagnostics can point us in the direction of rejection, they can't yet tell us which type of rejection is present, and that is necessary to guide our treatment. Hopefully in the future, we will have that capability. And I know that's something that Sean Agborino is actually working on discriminating different types of rejection based on blood-based biomarkers. So I'd like to turn it over to Sean for my next question. If we could just advance the slide, please. Could we show the next discussion question, please?
Quran, are there any questions from the audience here? From the
So there
there
are questions in the Q&A. One is from Dr. Feng, actually. How useful is a biomarker of quiescence to potentially reduce immunosuppression? This may be the use of a biomarker in liver transplant, but heart transplant may be very different. That's a great question. And actually that has not been prospectively studied as yet in heart transplantation. I believe there are trials that are about to be launched looking at immunosuppressive titration based on non-invasive diagnostic results. And Sean, perhaps would you like to comment on that further?
Yes, I would like to say I think it's an intriguing question, and we cannot just wait for the heart studies to really begin and give us some insight. Because if you think about it for a moment, some of these biomarkers, whether it's a molecular microscope or it is donor-derived cell-free DNA, they are indeed biomarkers of injury. And if you think about that, if the goal of immunosuppression is to reduce end organ injury, then you may want to think that a reasonable and insensitive marker of end organ injury could be used to titrate immunosuppression rather than using drug levels or tacrolimus 12, which we all know is quite variable between patients. Therefore, some of these heart studies, which are going to start soon, are asking that question. If monitoring a marker of end organ injury, such as cell-free DNA, would that be better to guide immunosuppression management than what we currently do? I think the results of these trials would be quite informative. That's a very intriguing question.
You know, we are starting that in the Mosaic trial. And the Mosaic trial is basically looking at low levels of cell-free DNA. And if there are low levels of cell-free DNA, then immunosuppression will be decreased to levels that are actually lower than what the general community is looking at. So it will be a randomized trial of using cell-free DNA and lowering immunosuppression versus routine therapy. And so I think this is going to be very informative, as you pointed out, Sean, in terms of whether or not we can use these biomarkers to actually reduce immunosuppression in that light. So this will be the first so-called utility trial in terms of the biomarkers. It's a very large trial, like several hundred patients. And so I think it's going to really tell us, maybe give us some answers for that as well. I think we had some other questions, Karan.
There's a question from Dr. Valentine as well. I'd like to challenge the idea that we need to do a biopsy when we have an elevated donor-derived cell-free DNA, especially given the observation that elevated cell-free DNA precedes biopsy evidence of rejection. We need a randomized trial. And I think that this is precisely what some of the studies that are in various stages of either being launched or planned will hopefully address. It's true that since cell-free DNA is such a sensitive marker of graft injury, we now know that the cell-free DNA levels can start to rise weeks to months before biopsy even picks up rejection. So in the cases where we sometimes call a false positive cell-free DNA result, this may actually be a true positive and the biopsy is just not reflecting that injury pattern as yet. Luciana, did you want to add anything?
No, I mean, I agree with you, and I accepted the challenge raised by Hannah. The point here is that it's difficult. Well, of course, we know when we are in a phase where rejection is highly prevalent, like in the initial phase after transplantation, it's okay. But on the other hand, we still need to understand more and probably to have more specifics about what is causing the rise of cell-free DNA in the blood, and this may be more helpful because, as I said, it's like troponin, no? But with troponin we have other symptoms. With cell-free DNA and heart transplant, at least in these settings, we only have the biomarker. So probably we should try to address the issue also with a multifactorial approach, not just one biomarker to rule out or rule in a diagnosis. But if we want to make it non-invasive, we probably need more than one biomarker, or a biomarker coupled with imaging.
Let me chime in. I think, Luciano, you really hit the nail on the head too. Having another biomarker would be helpful. For example, donor-specific antibodies. If you had DSA and had an elevated, cell-free DNA, that would suggest that you're working along humoral lines, and that would be very helpful to look at anti-humoral therapies as opposed to anti-T cell therapies. Whether it's, and that's, I guess, an issue with cell-free DNA, right? We don't know whether it's cellular rejection or antibody rejection. And so to have another biomarker that would at least suggest in what direction, it would tell us what strategy we might want to follow. But that also tells you about the biopsy, because a biopsy is not totally everything there, but if you use intragraph mRNA transcripts, whether it's molecular microscope or whether it's a nanoscope, and with the nanoscope, you can actually go to the paraffin blocks, so you don't have to do another biopsy. You can just go right to these biopsies, go right to the paraffin blocks, and look at intragraph mRNA transcripts. That actually may tell you even more in terms of cellular versus antibody-mediated rejection, because the treatments could be wholly in terms of how you approach them, but also in terms of follow-up, as well. And who knows indicators, right? And Luciano, you mentioned about the injury patterns. Yeah, we see that with the molecular microscope, and that is actually what is more prognostic. That we actually see some of those lies through intragraph mRNA transcripts. We might treat in another direction depending on what the other transcripts show us. So I think it's both ways. Biopsy maybe intermittently might help in that light, but we would like to know what we're treating. In terms of an elevated cell-free DNA by itself, we would like to have some indicators.
If I can add here, John, for 1 minute, with time permission. It is true that the current cell-free DNA test, as it is, the levels, the specificity for AMR versus ACR, it's low, but it's there. AMR generally has higher levels of cell-free DNA than ACR. And I think however, there's some additional cell-free DNA qualities that are suggestive of one condition versus another. Again, this is not in clinical use yet. However, it's on the translational plane and moving towards that. What do I mean? If you think about cell-free DNA, it has different features: the length of the cell-free DNA fragments, the proportion of certain genomic elements, such as promoters and others. And these different elements, they differ between AMR and ACR. So it's true that the cell-free DNA test, as it is now, can differentiate AMR, but with really not very good test performance for differentiating those two conditions. However, the translational studies that are on the way, which would suggest that there is a brighter light at some point on this biomarker towards improving on its specificity.
Thank you, Sean. So perhaps I'd just like to point one question towards Howie, which is, now that we've had these discussions about the strengths and weaknesses of different biomarkers and biopsy, what is our gold standard? When we do studies, what do we compare to? I think we can all agree that the biopsy is no longer a great gold standard. Do we even have a gold standard anymore for rejection diagnosis?
Yeah, I would say it's TBD. It's to be determined. We actually knew going back almost 20 years in the original cargo study that there were problems with the subjectivity of interpreting biopsies just when we need them, which is 2R and above, where our treatment threshold. So that really made it a tarnished gold standard. And it's always good when science can be reproduced, and cargo 2 reproduced the same findings. So I think we've relied on biopsy perhaps to tell us what's going on if patients present clinically with symptoms of rejection or graft dysfunction, or if there are abnormalities in gene expression profiling or in donor-derived cell-free DNA. So I think what we're seeing now is we're seeing an evolution, as Sean mentioned, of more sensitive biomarkers that can distinguish between AMR and ACR. And also a lot depends upon when these tests are obtained temporally. So if it's beyond the first year post-transplant, one starts to think about cardiac allograft vasculopathy, whereas within the first year, we don't. But the other thing is, and John in the e-image study showed that you can actually use at least gene expression profiling to guide steroid withdrawal. So we know we can use this to adjust immunosuppression. And there have been some single center studies from the Mayo Clinic, Scottsdale, for example, where they were able to not just wean steroids, but adjust the tacrolimus levels. And then from the original image study, they identified a cohort of patients with lowest quartile of gene expression profiling scores who had very low likelihood of developing rejection, could be weaned off steroids, so an immunoprivileged population. So I think, and now we're looking at using these tests to determine treatment and weaning of immunosuppression. So I think at this point, we really can't say TBD, but it will be determined on the basis of future studies, clinical trials, and so forth. I think the molecular microscope does add some interesting dimensions. I guess the question I've always had is, how do you respond clinically to the results? There's really no data about treating findings of injury there. And I think, I'm not sure if there will be or not. But, the numbers of biopsies are going down. At your program, Kieran, you do only a small number, I think
We
two.
do 2 routine biopsies.
Yeah, and that's our aspiration, is to do 2, but we're in John's all-in study and they want us to do 6. So we're at 6 at this point. But I think that once we get past that and we have the results, the data, we'll probably be joining you. And I think a lot of people will be as well. So I think that's my answer. If I left anything out, or if it's confusing, that's because it is confusing. And I think we'll know a lot more in the next year or two as we get more data, clinical trials, studies.
Thank you, Howard. I think this has been a great discussion of the first paper. I want to make sure that we have enough time left for the paper on clonal hematopoiesis. So maybe I'll turn it over to Sharon for her next question.
Thanks, Kieran. Thanks, John, for advancing the slides for me. So I'm going to switch to referring to clonal hematopoiesis to CHIP, which is a lot cooler and a lot less of a mouthful. So as explained, this is a novel marker that appears to be linked with inflammation. And has been shown to be a major risk factor in atherosclerotic cardiovascular disease in particular. And I'll direct this question to Sean. How do you think the results of this and this paper that summarized before is relevant in the field of transplantation?
So thank you. I want to say really just by thanking AJT for publishing this paper and introducing this in the field, because this is a mind-blowing concept. It's truly blowing the screen out in other disease profile, whether it's stem cell transplant or other areas. So opening up this in transplantation in our journal, I think that was just a great thing. I'm sure the paper was quite good and the reviewers liked it. So I think it was a really good review. I think, in my view, and this is an opinion, I think it's not only relevant to transplantation as this paper clearly demonstrates. I also think that studying this in transplantation, where you can time things and relieve certain stresses from the body, would be quite relevant to study basic principles of CHIP that you can now transfer back to other disease conditions, and I'll explain that in a little bit. So let's see, but just for the sake of everybody read the paper, this it seems to be quite common in transplant based on the data from this patient. On average, the patients with CHIP here had an age of about 54, and in this population, the average age is somewhere around 48, and the incidence of CHIP was 20%. That is very high. If you compare that to the non-transplant general population, it is at age between 70 and 80 in a normal population that you would see clonal hematopoiesis of that same frequency. So it seems to happen in transplant patients at a younger age and at quite high level. That's the second. And then the second observation is that the variant allelic frequency, which is the frequency of the mutation in that patient, was 8. Generally, you say a threshold of about 2 or higher, you would consider that the patient have CHIP. Our patients here are having median levels of about 8. So it's not only more frequent in heart transplant patients, the frequency is quite high. And despite the short follow-up of this of the study, 3.2 years, you could show a mortality difference. If you go back and look at the other studies in heart in the general population, looking at heart atherosclerosis and other, they needed a much longer follow-up and a bigger population. What that gives insight to is the effect size. I think that the effect of this condition in transplantation is there. It happens earlier, and the effect is quite significant. That's how you could see significant differences in a very small population of patients. So not only is it very significant, I think that we can learn something and put it to other conditions. That's point number 1. Point number 2, and I'll stop there. CHIP in transplant here, high frequency of allelic, high variant allelic frequency that you could see. CHIP is associated to inflammation. These patients have higher levels of IL-6, IL-18, IL-1B, and several of the inflammatory cytokines. These are not good stuff. These are, as has been shown in other conditions, this is like really bad markers. Fortunately, there are very good targeted therapies for this. So another idea that this paper raises in my mind is, you don't have to, do you have to give anti-inflammatory therapy to everybody, or could you use this as an indicator, as a biomarker, to select some of the patients where you would then target this anti-inflammatory therapy and then look for long-term effects? Not only would it benefit heart transplant patients, but could that same condition be brought back to other conditions such as GVHD and others? So I spoke a lot, but in summary here, 2 things. I think number 1, it's very relevant in transplantation. It's quite common. There's indication from this study that the effect size is quite significant. Then number 2, it raises this issue of inflammation and disease. Could you taper inflammation to improve outcome in disease? I think transplants could be the place to do these 2 things and then bring it back to everyone else. And I'll stop here. Very exciting topic.
Thanks very much, Sean. I think that leads very nicely into the next question, which we thought we would direct at you, Luciano, which is that since this is linked with inflammation, do you think that there would be a role for anti-inflammatory therapies to improve outcomes in transplant patients with CHIP?
Well, yes, that is this is a relevant point, and I think that it's a point that is worthwhile investigating. We know that there is a bulk of observational studies supporting the concept that aspirin can have some protective role in our transplant recipient. We don't have a prospective randomized study, but the bulk of evidence is out there, and somehow is quite convincing. So we don't know if the benefit of aspirin is related to the anti-inflammatory effect or is just for coronary protection effect. This is something that is clearly unknown. And this finding of this inflammatory marker is relevant towards this hypothesis. And together with this, we also know that there are also other early studies with CRPs and with other general inflammatory markers showing that inflammation is markers of inflammation are biomarkers for prognostic stratification in these patients. In this specific study, what I think it's, however, something that needs to be taken into account is the timing where the effect is seen in the prognostic stratification. Because if we look at the Kaplan-Meier of the study, majority of the death in the CHIP group happened immediately after transplantation. So this is something that may be also connected to the post-transplant complication that may rise. So probably the follow-up is not long enough to capture the effect of CAV on prognosis, but if we look at those Kaplan-Meier, the effect is just immediate after transplantation. So I would challenge also even the panel and also the audience, if not using CHIP as a marker after transplantation, but to use it as a marker of risk before transplantation in the screening, also because in most of these patients, the sample was taken before transplant, not after transplant. So this may be also something that we can consider and discuss about.
Luciano, this is John. I think that's a great idea. We are doing the NIH tocilizumab study, the anti-interleukin 6, where we are drawing baseline mechanistic studies. So in a way, we will look at all those biomarkers that Sean had been mentioning. We'll be looking at IL-6, IL-17. We'll be looking at IL-6, basically all of the inflammatory biomarkers that we already have blood stored. And we'll see whether or not the anti-inflammatory role of tocilizumab really has some benefit here. At least in animal studies, we do see a decrease in transplant vasculopathy. So, and of course, and also decrease in antibodies, de novo antibodies. So I think, if anything, this may be right on in terms of truly designating who is at an increased risk for inflammation, and maybe, just maybe, some of our therapies may be helping to decrease that inflammatory state. That's that.
Yeah, I think that was an intriguing component of the study, that they actually took the blood in 2/3 of the patients before transplant. It would be interesting to actually see if there were differences in those two groups with blood taken before and post transplant. So our final question is for Howie. Given particularly all the RCTs and CAV and mTOR inhibitors that you've been involved with, perhaps you could give us some insight into what type of and scope of study would be required to properly study the role of CHIP in heart transplant outcomes in terms of design and endpoints.
Thank you, Sharon. So as was mentioned, this is mainly retrospective, so that's always an issue. As Luciano said, it seems to be predictive of early badness rather than later badness. So, going forward, we'll need to do this prospectively. John mentioned this being done in the all-in study of tocilizumab. That may provide some data, but perhaps a study that looks at people, as you mentioned, pre-transplant, so perhaps can predict early rejections or PGD, and then post-transplant to see if it can predict bad outcomes further down the road. I think that would be important. Once we define that in terms of prospective observational study, so we are now all convinced that this is the case. I mean, it seems to make sense, as Sean said. I mean, CHIP's associated with all these bad humors and bad karma that we know cause mischief. So it does make sense, but we need to show it prospectively. Then at that point, we can use it as a biomarker and determine whether we can stratify people into those who are going to have bad outcomes, like CAV, and so we can identify a population where the benefit to risk ratio of using things like mTOR is in favor of using the mTORs as opposed to a lower risk population where it isn't. So this may be the guide, once we define this prospectively, this may be the guide going forward for future clinical trials, sort of like a biomarker version of the iBox, where a number of donor, and John knows about this, leader in terms of defining its utility, defining 4 trajectories of people post-transplant in terms of what happens with CAV. This may be a biomarker version of that in terms of identifying people who have trajectories that lead to CAV and increased mortality.
No, Howard, you talking about the cardiac eye box, and yes, it is taking into account these type of biomarkers, and it's using basically artificial intelligence and machine learning to actually predict who's going to incidence of transplant vasculopathy. And so it's really, as Sean and Luciano and you have pointed out, it's using these biomarkers per se to really hone in on risk stratification.
Mhm.
We completed a study with the Columbia group looking at severe PGD. And we looked at the biomarker samples, and what we found was a highly inflamed state for these patients before, at the time of PGD. And the tropomyosin was the largest inflammatory marker that we saw. But we saw about 20 different highly inflammatory markers. And so that would, again, suggest maybe what John is suggesting, that patients may be preordained to some of these complications because of their inflammatory state. And again, it's probably a perfect storm in terms of ischemia, et cetera. There's many risk factors that go into PGD. But if you're already having an inflamed state to begin with, that might tip you over into a clinical phenotype in terms of PGD. So, so I really see a nice correlation here where we can use these biomarkers to maybe even preempt bad complications, as you point out. All right, so other questions at this point? Well, let's move on, because we do have some interesting concepts here as well. Something I just wanted to throw across to our panelists and to my co-moderators here too. The theme here has been biomarkers, and also with T-cell rejection, antibody-mediated rejection, and what we have available right now are these markers. Well, of course, the endomyocardial biopsy is what we call the gold standard, but as we all know, it's not quite the gold standard. We have circulating antibodies, HLA antibodies, non-HLA antibodies. We have gene expression profiling, donor-derived cell-free DNA, and also with the use of intragraft mRNA transcripts. Now, yes, we have digital pathology, on the horizon right now. Many groups are looking into that. We also have the microRNA and exosomes that are, on the horizon as well. So these are 3 questions that I wanted to pose to any one of our colleagues out there. What is the most impactful use of a biomarker or a diagnostic test in transplantation? Is it to detect rejection? Is it for risk stratification in terms of who's going to do well? Is it like prediction of who's going to develop CAV and the like? Karan, you've got a lot of experience here. What should we be looking for in terms of this biomarker or diagnostic test?
Yeah, so, in thinking about this a lot, I feel like we're still in this era of protocol medicine and transplant where we tend to treat most of our patients the same way. And often that's not standardized. I mean, what we do at one center may be very different from what's done in another center. And I think the ultimate goal is to personalize therapy for our patients. So if we're given an individual patient, how do we make management decisions about should they get induction? What type of maintenance therapy should they get? How quickly can we wean their steroids? How high do we need to run their CNI levels? So I think this is really the power of these biomarkers and non-invasive diagnostics. My hope is that ultimately they'll allow us to better titrate and personalize immunosuppression for our patients, to really give more immunosuppression to those who need it, and then to wean immunosuppression more quickly in those who don't. and ultimately really prevent these long-term complications that are still the Achilles heel of transplantation.
Yeah, great response. I mean, I agree totally. I mean, I think we really do have to get to a customized therapy. Not everybody is the same, as we are getting to know. So which biomarkers should be used in combination? I think, how you had mentioned, maybe using some combination of biomarkers. Any combination strike you as being maybe more relevant than others?
Well, I think probably the combination of donor-derived cell-free DNA, gene expression profiling, and maybe DSAs would be beneficial at the start. There are a number of others that you mentioned are sort of on the horizon: digital pathology and also exosomes, but they're not. I don't think they're not ready for prime time. So I think the things where we have the biomarkers where we have data. Luciana also mentioned early on imaging, which is crucial as well in terms of looking at graft systolic function and morphology. So I think there are a number that we can use. And then, of course, clinical judgment, just how's the patient doing clinically?
Absolutely. I couldn't agree with you more. And there's a lot on the horizon, particularly digital pathology as well. So Luciano, what are the unmet needs and areas of future investigation?
Well, one of the major unmet needs is what Kiran outlined. So the need of a biomarker or a combination of biomarker that allows us to customize the immunosuppressive therapy. Something that I'm not seeing here in this list of biomarker is an immune function biomarker, because we are very much focused on something that is in the graft. But we know that we have more patients dying of infection than patients dying of rejection. So, and this is a marker of how we over immunosuppress most of our patients. So I think that to improve the sensitivity of this evaluation in a multimodal fashion, it can be interesting to add an immune monitoring biomarker. We know that the immuno was more fashionable a few years ago. Now I don't know how much it's used in its clinical practice in US. It somehow slightly is in our centers. We are using it sometimes, but I think that trying to combine something that goes in that direction to something that is for graft injury, like cell-free DNA or antibodies, can improve the detection, can improve the personalization of therapy.
Excellent, response. And you're quite right. Having a test, we use the old, what we call the Silex test, or the T-cell immune function test. And that had data that was kind of all over the place, but it may have been helpful for over immunosuppression, looking at CD4 cells and ATP production. And that was the basis of that test. And whether or not that may be helpful, but I think you're right on. Something like that needs to be done in terms of how immunosuppressed our patients are. Because I think all of us believe we're over immunosuppressing our patients. Maybe the cell-free DNA mosaics trial will help shed some light on that, but certainly this is an unmet need and something we really need to get to. Let me finish this off just with some fun, okay? So what I did was put together a little vignette here in terms of a case study. There's no right or wrong here, but it's just an idea of what we're dealing with in terms of these biomarkers per se. We'll probably get through one case here, but this is in 2013, a 63-year-old white female with dilated cardiomyopathy, diagnosed in 2002. So in 2013, undergoes heart transplant with triple drug therapy. In November 2013, admitted with reactivation of CMV. 2014, weaned off steroids, no significant rejection to date. Surveillance biopsies and CATH and DSA, donor-specific antibody, are all negative. Now in 2019, so we're 6 years out now, Normal function, ejection fraction 55%. Historical allomaps between 31 and 34, so kind of getting to that borderline. Allosure have been less than 1.3, so again above the mark, the 0.2 that people are content with. And so now in 2020, an allosure comes back at 2.7 in conjunction with an allomap of 35. The biopsy again is done because of a safety biopsy, because of the elevated allosure here. It's negative again for ACR and acute cellular rejection, acute antibody-mediated rejection. And the DSAs continue to be negative, but now the ejection fraction is down to 40%. So what do we do? Do we treat empirically? Do we do some other testing? Come on, what would you do here?
So what I would probably do, one thing that I would do is send for non-HLA antibodies. We've seen several cases where patients have presented with graft dysfunction and high donor-derived cell-free DNA levels. And we're all scratching our heads trying to figure out why, because the biopsy was negative, there were no HLA antibodies. And then we ended up finding angiotensin receptor antibodies or MICA antibodies, suggesting that they did indeed have AMR from non-HLA antibodies. And I think there's kind of evolving literature about the role of non-HLA antibodies, and we're recognizing more of these antibodies. And so I think that's an area of hopefully further investigation in the future, but that's something that I would look for.
Yeah, no, absolutely. We thought about that as well, so we did send them off. But again, we did a molecular microscope on this. So we just did another follow-up biopsy on this. We were concerned because the ejection fraction was down. And what did we find? The MMDX showed not well, antibody-mediated rejection. You read it, abnormal heart transplant biopsy with ABMR, no T-cell mediated rejection, some parenchymal injury, which was slight, and mild parenchymal dedifferentiation. The HT1s were abnormal. So again, this is not so bad. And but it was quite indicating to us that maybe there is some non-HLA, because we didn't see any HLA antibodies here at all. So you were quite right, Karan. We were quite concerned about that. So we looked at AT1 antibodies. Okay, you're right on. So it was 18. Now the upper limit here, if you saturate the beads, will be 40. But the 18 was still of concern to us. But because the ejection fraction was down, we completed plasmapheresis. Our usual therapy is plasmapheresis, IVIG followed by rituximab, and then completing IVIG again. Our allosures a couple months later came down. Our AT1R came down a bit. We also did a cath later on. Normal coronaries, LV function, somewhat improved from 40 to 45%. Again, at that same time, we did a follow-up biopsy, ACR, AMR still negative, DSA remains negative, but the ejection fraction is still down, still bothering us. So we do, when we did the biopsy, we also sent a piece off to the molecular microscope to see what we're doing, whether or not we're resolving the issues or not. I don't know, Howie, what would you do? Ejection fraction still down. Concerned about still some activity that we're not seeing.
And what was the response of the activity to your therapies? Still ongoing?
So the molecular microscope says persistent AMR. So, it's still there. DSAs remain negative. So again, now what do we monitor? Do we just treat?
Well, the fact that the EF is down significantly is of concern. So I guess, did you look and see if the patient has CAV? I'm sure you did an angiography and that was negative.
We had done an angiogram that was negative.
Okay.
Normal course.
So I guess do you continue? And I have no experience interpreting these diagrams. You can call it that, but I take it this isn't better. The post-treatment isn't better than the previous one. Is that correct? Do we know?
Still persistent antibody.
Okay. So I guess you just continue doing what you're doing push on and with the therapies and see if they work. That's all you can do. I mean, again, you don't want to, as Sean said, infections are our big fear. You don't want to blast the patient and then have them succumb of infection. So, but I guess that's what I would do. We have one patient who we don't have anywhere near this type of significant data. We don't have any evidence of any DSAs or any non-HLA antibodies, but the patient has had a persistently lower GF in the low 40s, asymptomatic. And so we just decided, instead of blasting with immunosuppression, to use GDMT, heart failure, good old fashioned GDMT, like a country heart failure doc. But that's what we decided to do. So, and actually the patient's EF improved somewhat. So who knows?
I think, and studies have demonstrated that the antibodies, does not actually lead to poor outcome. When you look at the MMDX studies, that really and truly has been the case. It's really the injury patterns, which we really didn't quite see here. So Sean, say we found, highly inflamed molecules floating around. Would you treat on that basis? I mean, we're seeing something here, whether it's the AT1R antibodies or not, it's still a concern to us, but would you be concerned?
Yes, no, I think the patient has multiple signs to show us that something is very wrong. The biopsy is persistently positive. The cell-free DNA levels at 1.5, those are high levels, even though they came down, albeit low. Those are pretty high levels. The EF is down and remains down. The question then becomes, and I don't have a lot of experience in hearts here, is should we not consider that that patient has persistent AMI? What second line of therapies should we be considering? I think, there is ample evidence showing us that something is going on, it is bad. And if we leave it there, bad things may possibly happen to this patient. Is this a point where one should start considering that the current therapies for this patient are not abating the problem that's there, that we can see, that we should now think about other lines of therapy at this point? I want to turn it back to you, John, if you don't mind me bringing you back in that discussion. Are these second line therapies that, you could, or how would you think about it in this case where, in my mind, there is evidence that it's an ongoing problem, it's defined? Is this where you bring second line therapies?
Yes. Yeah. So what did we do? We did photophoresis in this case.
Yeah.
And we chose photo instead of tocilizumab. It's because we did not see DSA. We were thinking about the AT1R, but I experience whether we go with photo or we go with tocilizumab, we've said some good benefit. And there are many studies that demonstrate that LV dysfunction of this nature, the Kirkland studies from UAB demonstrated that photophoresis did have benefit in these type of patients. So we went ahead and did this, and actually we had resolution of the depressed ejection fraction. We came back up to 55–60%. So we came out with a good benefit. Sharon, you have a final comment here?
I don't think it will be a final comment, but I just wanted to comment that, I think this sort of a patient at our center, we don't have access to a lot of these markers, but we do have access to MMDX. I must say that we would have engaged some more advanced imaging at this time. So MRI as well as FDG PET to show that you have got active inflammation that is suggested by one test here. Before sort of embarking on sort of second line or third line aggressive AMR treatment. But it's great that you had a good result.
Well, thank you for that. With that in mind, I'd like to thank our co-moderators, our expert panelists. This was a great discussion overall. And, as our first foray into this AJT miniseries, I think it was quite successful. Again,
Thank you, John. As I said, when I accepted the invitation, I learned something. So
great.
thank you very much, everybody.
Thank you, everybody.
All right, bye-bye. We'll see
Thank
you in
you.
April in Denver.
Bye-bye.
Thank you.
ISHLT.
Thank you. Bye-bye.